Paul, for this study, to me this is kind of practice changing for many of us, because when I was giving neoadjuvant, maybe for locally advanced or borderline, I sort of thought I had a choice. I thought I had a choice between maybe nab-paclitaxel gem and FOLFIRINOX, and depending on the performance status of the patient, you know, there's some patients you just can't give FOLFIRINOX to very many cycles. What do you think this adjuvant, negative adjuvant data does to those folks that are getting thinking about neoadjuvant?
So I don't think it answers it clearly, because that was not the question in this study. And the same way in the metastatic setting, there is still some ambiguity, and certainly some patients who benefit from gem nab-paclitaxel, it's more tolerable maybe, and get some really good responses. There may be some people in the neoadjuvant setting. I think some of it depends on whether your neoadjuvant patient is really a surgical patient who you're preloading the chemotherapy, in which case FOLFIRINOX, in my opinion, is the clear winner.
If you're really giving the adjuvant
if you're really giving the or if they're so locally advanced that you really don't think they're going to get to surgery, in which case you may be treating them as a metastatic patient, where there are some settings where it would make sense to give gem nab-paclitaxel.
Yeah. Anybody disagree with that?
Yeah, no. I think that's a really good point.
And any other new data around neoadjuvant that has come out at this meeting in terms of shifting practice patterns? Anybody?
I think the big one was in ASCO GI, as I said, the Japanese study which came out for resectable cancer patients with the neoadjuvant. So I think that's fairly, and we've got other trials which are going on through the through the different cooperative group networks about GA versus FOLFIRINOX, and that we are seeing. But really looking at the whole data, if you look at it, I do think FOLFIRINOX is for patients who can tolerate it as a fairly solid regimen, at least in the adjuvant setting. That's I mean, the survival curves were amazing in those FOLFIRINOX. Again, they had good patient selection, but still they had median overall survival of 54.4 months. I mean, that's like, it just kind of when you looked at those curves last year in ASCO, you were like, that was amazing to see in patients with pancreatic cancer. I think
and that didn't make the plenary.
That did make the
we can discuss. Yeah, we can. Yeah. So I think all of us were fairly disappointed about that, but because that was truly, I think, practice changing. The other thing I want to, for our audience, is that when you look at FOLFIRINOX, the original trial, they gave bolus 5-FU, irinotecan at 180 milligram per meter square. But when you look at the adjuvant study, no bolus 5-FU. In the clinical setting, I don't think anybody really gives bolus 5-FU. And then the irinotecan was decreased to 150 milligram per meter square
after a while.
And then because of tolerability. So I really do think when you look at FOLFIRINOX, a lot of the data we have about tolerability at these higher doses. So when you really dose adjust the FOLFIRINOX, I think it really is more tolerable in patients.
Anybody do something different than that in terms of your modification? Drop the bolus, reduce your irinotecan. Anybody fiddle with it more?
We give a lot of growth factors.
You give growth factors. The only time I ever give a growth factor.
I give a lot of hydration.
So you keep regular dose and give growth factors.
No, I do this and give usually every other cycle, but we almost always start with cycle 1 unless they already have a good count, and then do cycle, depending on what they need.
So it's much more involved. It raises the cost of the regimen.
But we also like them to come back. We often have them come back week 2 and just get hydration and check in.
That's what
So my thing,
how much is parking at your place?
I normally don't give growth factors.
I mean, this is
my place. It's a big deal.
They go to the satellite.
But I tell you, we normally don't give growth factors, but I do think a good anti-nausea regimen is very important in these patients starting off. Because the people who get the nausea and everything, if you're not getting for the delayed nausea, then you can really get into trouble. So I do think if the ones who get into trouble, hydration is very important. It's amazing how a bag of hydration can make these patients feel.
How many cycles?
In the adjuvant?
So, 12 cycles is the
Who does that?
We try.
We try to get there, yeah.
Even in the trial, they couldn't
couldn't,
do.
yeah.
Right? I mean, the
try.
percentage
I
of
don't
patients
even try, I have to tell you.
We treat it like colon cancer, and we
yeah.
aim for 12, advanced colon cancer,
Yeah.
advanced localized colon cancer. We drop the oxali like everyone, 6 to 8 cycles in.
Yeah, I only shoot for 6, I have to just tell you right now.
And then
I
do you
think we're
continue
done.
the...
Well, but I do some funky stuff beyond
I
that.
know.
So,
but I think
I'm a big
I think
guy,
the standard obviously you get into toxicity and everything, but the standard was 12, but a lot of people couldn't get to it. Those adjustments. I'll tell you another thing about FOLFIRINOX is what we looked at our retrospective data in patients more than 75 years of age. Now, if you remember, the original metastatic setting did not include these patients who were more than 75. We looked at our retrospective data presented at ASCO GI in January of this year. In those patients in which you dose adjusted, again, those patients, and our oldest one was 83 years old who got FOLFIRINOX. They actually did fairly well. I'll tell you the irinotecan dosing was mostly 120 milligram per meter squared. That seems to be fairly tolerable when you decrease it. and the oxaliplatin was between 65. A lot of people got reduced to 65 milligram per meter square, but our survival in frontline for these metastatic was about, again, it's retrospective, small numbers, was about 11 months, which is very similar to what it was.
Still have miles to go.
Yeah, I think there still needs to be a point for the community oncologists in terms of FOLFIRINOX. We do all of these adjustments to support the patients because it is a difficult regimen. Yeah. And at the end of the day, I think that we can't lose sight of that. You do need to select patients carefully. It's after a Whipple or another major surgery, a distal pancreatectomy. It's going to be a major surgery. It's going to be difficult, and even with these modifications, all the supportive care that we do, it's not easy therapy. And so I think we are blown away with the 55-month survival. I mean, and so
well, again, that's selection too.
That's selection too.
But I guess completely against
and
that.
of course, if you can fly and make it through, Bush Airport and get to your hospital, that means you're 55 years old. You're not 78.
I completely agree. So I think there's patient selection.